Good morning, students. Today we will see about RH incompatibility. RH incompatibility possibly only when expectant mother is RH negative and the fetus is RH positive. If an RH negative individual receive an RH positive blood, there will not be any immediate reaction. The isoimmunization or alloimmunization is defined as production of immune antibodies in an individual in response to an antigen derived from another individual of the same species provided the first one lacks the antigen. Methods normally fetal-maternal mixing is not possible, but in cases of induced or spontaneous abortion, ectopic pregnancy, amniocentesis, extracephalic version following a normal delivery or operative interventions, the fetal-maternal leak occurs. When Rh positive cells enters the Rh negative woman, there is no immediate destruction of Rh positive cells as there is no natural Rh antibodies. The IgG is an albumin antibodies produced about in 6 months after fetal maternal leak. On the subsequent exposure to the antigen previously formed, beta cells quickly produce IgG, which can be detected in the immunized mother in the next pregnancy. When the blood from a person who is Rh positive enters the bloodstream of a person who is Rh negative, the body reacts as it would be in any foreign substance and remain circulation for the remaining lifespan. After that, they are removed from the circulation by reticuloendothelial system and were broken down with liberation of antigen. It develops antibodies to destroy the invading antigen. The antibody production is related not only responsiveness of reticuloendothelial system but also to the amount of Rh antigen liberated. Therefore, the number of red cells that have entered the maternal circulation. Because this takes a long time, immunization in the first pregnancy is unlikely. Detectable antibodies usually develop after 6 months following larger volume of fetal maternal blood. Antibodies once formed, they remain throughout the life. To destroy Rh antigen, which exists as a part of RBC, the entire RBC should be destroyed. Destruction of Rh positive cells occurs in an Rh negative person after they become sensitized to Rh positive antigen. Theoretically, fetal maternal blood does not mix, but in reality, small placental accidents occur that allow a drop or two enter in the maternal circulation, initiate the production of antibodies to destroy the Rh positive blood. It can occur during a spontaneous abortion or during amniocentesis or chorionic villus sampling. Most exposure of maternal blood to fetal blood occur during the third stage of labor. Antibody formed in the maternal system, that is IgG, cross the placental barrier and enters the fetal circulation. The antibody will not have any effect on the Rh negative fetus. The fetus is Rh positive, the antibody becomes attached to the antigen site on the surface of fetal erythrocytes. The affected cells rapidly removed from the circulation by reticuloendothelial system. Depending upon the degree of agglutination, the destruction of fetal RBC, various types of fetal hemolytic disease may appear. The antenatal management, an Rh negative woman should do indirect comb test at first antenatal checkup, that is at the 12th week. If negative, this test repeat at 28th and 32 and 36th week. If negative at 36th week of pregnancy, it is allowed to continue and delivery managed on obstetric base. If this woman develop abortion, APH or if amniocentesis is performed, 100 milligram microgram of anti-D administered intramuscularly. If indirect comb test is positive in early pregnancy, antibody titer should be estimated at every month. Rising titer or titer of 1:16 or above, presence of albumin antibody and previous history of hemolytic disease in the sibling may indicate amniocentesis to determine the amniotic fluid bilirubin level and optical density. Even then, prophylactic anti-D 100 micrograms should be administered before amniocentesis. Amniotic fluid should be collected in dark glass bottle to protect against sunlight and preserved in the refrigerator in case any delay in transport. Optical densities compared with Lilly's chart, it shows that the fetus is safe if the optical density falls the zone A. Zone C is omnivorous and fetus requires intrauterine transfusion or prompt delivery if fetal maturity is 36th week or over. Zone B indicate the need to repeat amniocentesis in 2 weeks. Optical density reflects the amount of bilirubin present in the amniotic fluid. Amniocentesis is done between 28 to 30 weeks, at which the intrauterine transfusion is successful. If positive, near-term, premature induction of labor is indicated. Cesarean section is indicated on obstetric base. External transfusion should be arranged and cord blood sent at birth for bilirubin, hemoglobin estimation, direct home test and blood group and RH. Blood test for a maternal type and RH factor. If RH negative, indirect home test positive. If the titer is increasing, if the titer is not increasing, continue to monitor. If the titer is increasing, then we have to go for the following test. This is the chart of a patient who is having an RH negative blood. Amniocentesis, selection of time. No history of previously affected baby. It is done at 32 weeks and second test should be repeated after 3 to 4 weeks. Positive history of previous affected baby should be done at least 10 weeks prior to the date of previous childbirth. It is useless to perform prior to 20 weeks. USGs use invasively evaluate the condition of fetus, fetal liver size estimation, umbilical vein diameter measure. Doppler studies allow evaluation of cardiac function, blood flow in fetal vessels, venous pressure, and umbilical arterial blood flow indicate fetal anemia. Percutaneous umbilical blood sampling allows invasive sampling of fetal blood to determine the degree of erythrocyte destruction, HbA percentage, bilirubin, direct home test and fetal blood group. Intrauterine transfusion is direct infusion of all negative erythrocyte into umbilical blood transfusion. The transfused erythrocytes must be compatible with the maternal blood to avoid destruction of hair antibodies. The whole blood usually used to replace fetal serum proteins. Postpartum management. At birth, cord blood is obtained for HB, blood group and RH typing, direct home test, serum bilirubin count, administration of anti-D immunoglobulin within 72 hours of birth, antibody-mediated immune suppression. It blocks RH antigen of fetal cells. Intact antibody cut with fetal red cells are removed from the maternal circulation by spleen or lymph nodes. To prevent minimize fetal-maternal bleed, precautions during cesarean section, that is to prevent blood spilling in the peritoneal cavity, manual removal of placenta should not be done as a routine. Prophylactic ergometrin should not be given in this case. Amniocentesis should be done after USG localization of placenta. Forcible attempt to perform an extracephalic version under GA should be avoided. Manual removal of placenta should be done gently. Obstetric history. If the primary with no prior history of blood transfusion, baby will not be affected. In Paris woman, detailed previous obstetric history has to be taken with the history of prophylactic anti-D immunoglobulin following abortion or delivery. Other methods of fetal and assessment of fetal well-being include serial USG may detect hydrops and anemia. The important features are polyhydramnios, plasma thickness more than 4 cm, pericardial or pleural effusion, dilatation of cardiac chambers and enlargement of liver and spleen. Doppler flow velocity waveform in the umbilical artery, ductus venosus, middle cerebral artery have been used to detect fetal anemia and acidosis. CTG dysregulation in affected fetus, chlorosynthesis may be done to determine fetal HB and hematocrit. External transfusion is required if the HB percentage less than 10 gram, bilirubin level more than 15 milligram, and if bilirubin level rises by 0.5 milligram each hour or by 5 milligram in 24 hours. Direct home test is positive or previous childbirth or external transfusion, preterm baby. Liver and spleen are enlarged. Congenital hemolytic anemia is the mildest form of RH immunization. The baby's anemic and jaundice is mild. Peripheral reveals nucleated red cells and raised reticulocyte count over 10%. The child needs blood transfusion to correct anemia. Liver and spleen are enlarged. The baby's hemoglobin level must be monitored, and if necessary, a small transfusion of 30 ml of Paxil is given. Icterus gravis neonatorum. Lesser form of fetal hemolysis. The baby is born without evidence of jaundice but soon develops it with 24 hours of birth. While in utero, there is a destruction of fetal RBC with the liberation of unconjugated bilirubin, which is most commonly excreted through the placenta into the maternal system. A portion of bilirubin enters the amniotic fluid, perhaps from the fetal lungs or through the skin or across the surface of the placenta or the cord. That is why the baby is not born with jaundice. But when the umbilical cord is clamped with a continuing hemolysis, the bilirubin concentration is increased. The bilirubin rises to the critical level of 20 mg per 100 ml. The bilirubin crosses the blood-brain barrier to damage the basal nuclei of the brain, permanently producing the clinical manifestation of kernicterus. Treatment must restore hemoglobin level, reduce bilirubin level, and remove maternal Rh antibodies. Hydrospitalis, the most severe expression of fetal hemolytic disorder, a possible sequelae of maternal Rh isoimmunization. Infant exhibit gross edema, cardiac decompensation, and profound pallor from anemia and seldom survive. Often end in stillbirth due to severe anemia and congestive cardiac failure. Affected fetus looks pale and edematous, liver and spleen enlarged, and ascites may be present. Placenta is huge and pale and edematous. Edema causes the fetus to adopt Buddha position as a radiograph with a halo around the scalp. Intrauterine blood transfusion is necessary to save the fetus from IUD. Placenta also large and pale and has fluid oozing from it. Prognosis is poor. Hyperbilirubinemia. It refers to an excessive level of accumulated bilirubin in the blood and characterized by jaundice. Possible cause of hyperbilirubinemia in newborn include physiological factors like prematurity, excess production of bilirubin, disturbed capacity of liver, some disease conditions of the mother like GDM. Two types, physiological and pathological jaundice. Physiological jaundice, which appear after 24 hours of life, serum bilirubin never exceeds 8 mg per deciliter in term babies and 10 to 12 mg per deciliter in preterm babies. Highest serum bilirubin occurs in third or fourth day. Jaundice fades by 7th day of life, the baby is otherwise well. Etiology of the physiological jaundice is because of red cell breakdown. Neonatal HB is high compared to the adult and the span is only 60 to 70 days. Second one is liver immaturity. Neonatal liver may not produce sufficient glucuronide to cope up with a large amount of bilirubin which must be conjugated. Third, reabsorption from the gut. Peristalsis is slow and gut is not yet colonized with normal bacteria, which is responsible for converting bilirubin to stercobilinogen. This allows reabsorption of unconjugated bilirubin. Management. Early feeding encourages gut mobility and supplies glucose for the manufacture of liver enzymes. This also helps the gut to colonize. The degree of jaundice is to be observed and if it exceeds normal, serum bilirubin level should be measured. Pathological jaundice. The causes include bilirubin production, excess bilirubin production due to hemolysis. This may occur as a result of excess in number of RBC or due to deformed RBC or when there is extravasation of blood, such as hematoma or intracranial hemorrhage. Albumin binding capacity. If the plasma albumin is insufficient to carry the circulating unconjugated bilirubin, jaundice occurs. Conjugation. Many factors interfere with conjugation, especially metabolic disorders and deficiency of glucuronidase. Hypoglycemia and hypoxia both inhibit conjugation of bilirubin, as glucose and oxygen are necessary for the conjugation. Biliary excretion. Rarely conjugated bilirubin is unable to escape via biliary system and is returned to the bloodstream. Intestinal reabsorption. Any condition which slows down peristalsis allow more time for the reabsorption and unconjugated bilirubin. Management of pathological jaundice include goal of the treatment is to prevent the level of serum bilirubin from rising. Phototherapy. The bilirubin in the skin and superficial capillaries is converted to a water-soluble form during exposure to light in the blue part of the spectrum by a process of photooxidation. Extend transfusion. The brain damage is a threat to a newborn whose acidemia may increase development of kernicterus by increasing deposition of bilirubin in the tissue, irrespective of albumin binding status, whose blood-brain barrier is disrupted with sepsis. If unconjugated bilirubin escapes in the basal ganglia of the brain, it can cause irreversible damage. Only free unconjugated bilirubin is harmful because bilirubin which bind to the albumin cannot leave the blood spaces. Conjugated bilirubin does not damage the brain. Kernicterus is difficult to diagnose in neonate but may show signs of hypotonia, lethargy, poor sucking, and an abnormal Moro reflex. Later develop other signs of cerebral irritation and attenuated cerebral palsy. Hemolytic jaundice. Normally, no mixing of fetal and maternal blood during the pregnancy and labor, but when the placenta begins to separate, the chorionic villi tear and risk for fetal-maternal transfusion increases. In many cases, zero point 0.5 to 5 ml of blood enters maternal circulation and stimulates production of maternal Rh antigen. Once formed, these antibodies are permanent. Other occasions on which fetal-maternal transfusion occur are at abortion, amniocentesis, external cephalic version, or antepartum hemorrhage. In subsequent pregnancy, these small antibodies, which are type of immunoglobulin G, will cross the placenta. The fetus is Rh positive, they will attach themselves to the rhesus antigen, resulting in hemolysis. ABO incompatibility. In this, mother is classically O, group O and baby is A or less often B. The mother has naturally occurring antibodies like anti-A and anti-B. There are the type of IgM that are too large to cross the placenta. If the immune system produces small antibodies IgG similar to anti-A and anti-B, this will be able to cross the placenta and become attached to the fetal red cells and destroy them. This may affect the firstborn as much as subsequent child. Jaundice is usually mild but may appear within first 24 hours of life. If this happens, blood must be taken for grouping and comb test bilirubin level and also should be estimated. Treatment depends upon the serum bilirubin level and its rate of rise. Other causes of hemolytic jaundice include polycythemia, extravasation of blood, septicemia, glucose 6-phosphate dehydrogenase deficiency, and spherocytosis. Thank you for listening. If you have any comments, please let me know.